We will be talking today about morphologic patterns of immune disorders, and we'll look at two examples of rheumatoid arthritis and systemic lupus erythematosus. And we'll start with rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory disorder of autoimmune origin that principally attacks the joints, producing a non-suppurative, proliferative, and inflammatory synovitis. Rheumatoid arthritis often progresses to the destruction of the articular cartilage and, in some cases, ankylosis of the joints. Extra-articular lesions may occur in the skin, heart, blood vessels, and lungs. The prevalence in the United States is approximately 1%, and it is 3 times more common in women than in men. The peak incidence is in the 3rd through 5th decades of life. As in other autoimmune diseases, genetic predisposition and environmental factors contribute to the development, progression, and chronicity of the disease. The pathologic changes are mediated by antibodies against self-antigens and inflammation caused by cytokines predominantly secreted by CD4 plus T cells. CD4 plus T helper cells may initiate the autoimmune response in rheumatoid arthritis by reacting with an arthritogen, perhaps microbial or a chemically modified self-antigen. The T cells produce cytokines that stimulate other inflammatory cells to effect tissue injury. Interferon gamma from Th1 cells activates macrophages and synovial cells. Interleukin 17 from Th17 cells recruits neutrophils and monocytes. Rankle, expressed on activated T cells, stimulates osteoclasts and bone resorption. Tumor necrosis factor and interleukin 1 from macrophages stimulate resident synovial cells to secrete proteases that destroy hyaline cartilage. The synovium of rheumatoid arthritis contains germinal centers with secondary follicles shown by the star and abundant plasma cells shown by the arrow that produce antibodies, some of which may be against self-antigens. Many of the serum autoantibodies detected in patients are specific for citrullinated peptides in which arginine residues are post-translationally converted to citrulline. In rheumatoid arthritis, complex of antibodies with citrullinated fibrinogen, type 2 collagen, alpha-enolase, and vimentin deposit in the joints. Evidence suggests that the anti-citrullinated protein antibodies, in combination with a T-cell response to the citrullinated proteins, contribute to disease chronicity. Approximately 30% of rheumatoid arthritis patients do not have anti-citrullinated protein antibodies in the blood. About 80% of patients have serum immunoglobulin M or immunoglobulin A autoantibodies that bind to the Fc portions of their own immunoglobulin G. These autoantibodies are called rheumatoid factor and may also deposit in joints as immune complexes, although they are not uniformly present in all patients with rheumatoid arthritis and can be found in patients without the disease. It is estimated that 50% of the risk of developing rheumatoid arthritis is related to inherited genetic susceptibility. The human leukocyte antigen SLE class II locus is associated with anti-citrullinated protein antibody positive rheumatoid arthritis. Evidence suggests that an epitope on a citrullinated protein, vinculin, mimics an epitope on many microbes and is the target of CD4 plus T cells when presented by predisposing human leukocyte antigen DQ alleles. A second gene linked to rheumatoid arthritis, PTPN22, encodes a protein tyrosine phosphatase that is postulated to inhibit T cell activation. Numerous other genetic associations have been reported. Many candidate environmental factors whose antigens promote autoimmunity have been postulated. At least 70% of rheumatoid arthritis patients have anti-citrulline protein antibody in their blood, which may be produced during inflammation. Insults such as infection, including periodontitis, and smoking may promote citrullation of self-proteins, creating new epitopes that trigger autoimmune reactions. The inflammation localizes to the joint, recruiting macrophages and triggering activation and proliferation of synovial cells, chondrocytes, and fibroblasts. The production of proteolytic enzymes and cytokines contributes to the destruction of cartilage, and through increased osteoclast activity, it also contributes to the destruction of the bone, as shown on the picture. Rheumatoid arthritis typically manifests as symmetric arthritis, principally affecting the small joints of the hands and feet. Grossly, the synovium becomes edematous, thickened, and hyperplastic, transforming its smooth contour to one covered by delicate and bulbous villi. You can see on the left picture a schematic view of the joint lesion, and on the right picture you see synovial hypertrophy with formation of villi. The characteristic histologic features include synovial cell hyperplasia and proliferation, dense inflammatory infiltrates of CD4 plus helper T cells, B cells, plasma cells, dendritic cells, and macrophages, as on the picture, increased vascularity resulting from angiogenesis, neutrophils, and aggregates of organizing fibrin on the synovial and joint surfaces, osteoclastic activity in underlying bone, allowing the synovium to penetrate into the bone, causing periarticular erosions and subchondral cysts. Together, the aforementioned changes produce a panus, as shown on the left picture, a mass of edematous synovium, inflammatory cells, granulation tissue, and fibroblasts that grows over the reticular cartilage and causes its erosion. In advanced untreated cases, the panus can bridge the bones to form a fibrous ankylosis, which may later ossify as a bony ankylosis. Rheumatoid nodules are an infrequent manifestation of rheumatoid arthritis and typically occur in a subcutaneous tissue, including the forearm, elbow, occiput, and lumbosacral area. Microscopically, they resemble necrotizing granulomas, as shown on the right picture. Rarely, rheumatoid arthritis can involve lungs, leading to rheumatoid nodules and interstitial lung disease. Rheumatoid arthritis can be distinguished from other forms of polyarticular inflammatory arthritis by the presence of anti-citrulline protein antibody and by characteristic radiographic findings. In about half of patients, rheumatoid arthritis begins slowly and insidiously with malaise, fatigue, and generalized musculoskeletal pain. After several weeks to months, the joints become involved. The pattern of joint involvement is generally symmetrical, and the hands and feet, wrists, ankles, elbows, and knees are most commonly affected. The metacarpophalangeal and proximal interphalangeal joints are frequently involved, in contrast to osteoarthritis. Involved joints are swollen, warm, and painful. In contrast to osteoarthritis, the joints are stiff when patient rises in the morning or following inactivity. The typical patient has progressive joint enlargement and decreased range of motion, pursuing a chronic waxing and waning course. In a minority of patients, especially those lacking rheumatoid factor and anti-citrulline protein antibody, the disease may stabilize or even regress. Inflammation in the tendons, ligaments, and occasionally the adjacent skeletal muscle frequently accompanies the arthritis and produces the characteristic ulnar deviation of the fingers and flexion hyperextension of the fingers. On the left picture you see the so-called swan neck deformity. Radiographic hallmarks are joint effusions and juxta-articular osteopenia with erosions and narrowing of the joint space and loss of articular cartilage. On the right picture you see characteristic features that include diffuse osteopenia, marked loss of the joint spaces of the carpal, metacarpal, phalangeal and interphalangeal joints, periarticular bony erosions and ulnar drift of the fingers. Treatment for rheumatoid arthritis consists of corticosteroids, other immunosuppressants such as methotrexate, and most notably tumor necrosis factor antagonists. However, anti-tumor necrosis factor agents are not curative, and patients must be maintained on tumor necrosis factor antagonists to avoid disease flares. Long-term treatment with tumor necrosis factor antagonists carries with it increased risk of infections with organisms such as Mycobacteria tuberculosis. Systemic lupus erythematosus is the next condition that we'll check. It is an autoimmune disease involving multiple organs characterized by a vast array of autoantibodies, particularly anti-nuclear antibodies, in which injury is caused mainly by deposition of immune complexes and binding of antibodies to various cells and tissues. Injury to the skin, joints, kidney, and serosal membranes is prominent, but virtually every organ in the body may be affected. The presentation of systemic lupus erythematosus is so variable that a complex set of criteria for this disorder have been proposed to help clinicians and for the design and assessment of clinical trials. However, the disease is very heterogeneous, and any patient may present with any number of these features. Systemic lupus erythematosus is a fairly common disease with a prevalence that may be as high as 400 per 100,000 in certain populations. Although systemic lupus erythematosus often present when a person is in the 20s or 30s, it may manifest at any age, even in early childhood. Similar to many autoimmune diseases, systemic lupus erythematosus predominantly affects women with a female-to-male ratio of 9:1 for the reproductive age group of 17 to 55 years. By comparison, the female-to-male ratio is only 2:1 for diseases developing during childhood or after 65 years of age. The prevalence of the disease is 2 to 3-fold higher in blacks and Hispanics than in whites. The hallmark of systemic lupus erythematosus is the production of autoantibodies. Some antibodies recognize nuclear and cytoplasmic components, while others are directed against self-surface antigens of blood cells. Apart from their value in the diagnosis and management of patients with systemic lupus erythematosus, these autoantibodies are of major pathogenic significance, as for example in the immune complex-mediated glomerulonephritis, so typical of this disease. Autoantibodies also are found in the autoimmune diseases, many of which tend to be associated with specific types of autoantibodies. Anti-nuclear antibodies can be grouped into 4 categories: antibodies to DNA, antibodies to histones, antibodies to non-histone proteins bound to RNA, and antibodies to nuclear antigens. The most widely used method for detecting anti-nuclear antibodies is indirect immunofluorescence, which can identify antibodies that bind to a variety of nuclear antigens, including DNA, RNA, and proteins, collectively called generic ANAs. The pattern of nuclear fluorescence suggests the type of antibody present in the patient's serum. Several basic patterns are recognized: a homogeneous or diffuse, a rim or peripheral, a centrometric, and speckled. A homogeneous or diffuse staining pattern usually reflects the presence of antibodies to chromatin, histones, and occasionally double-stranded DNA, and is common in systemic lupus erythematosus. A rim or peripheral staining pattern is most often indicative of antibodies to double-stranded DNA and sometimes to nuclear envelope proteins. On the left picture you see nuclear membranes, and on the right you see cytoplasmic membranes. A centromeric pattern is indicative of antibodies specific for centromeres. On the picture, the pattern of staining of anti-centromer antibodies is seen in some cases of systemic sclerosis, Sjogren's syndrome, and other diseases. A speckled pattern refers to the presence of uniform or variable-sized speckles. This is one of the most commonly observed patterns of fluorescence and therefore the least specific. It reflects the presence of antibodies to non-DNA nuclear constituents such as SM antigen, ribonucleoprotein, and SSA and SSB reactive antigens. A nucleolar pattern refers to the presence of a few discrete spots of fluorescence within the nucleus and represents antibodies to RNA. This pattern is reported most often in patients with systemic sclerosis. On the picture you see a nuclear pattern that is typical of antibodies against nuclear proteins. The fluorescence patterns are not absolutely specific for the type of antibody, and because many autoantibodies may be present, combinations of patterns are frequent. Attempts are ongoing to replace microscopic assays with quantitative assays for antibodies against specific nuclear and other antigens. Indeed, antibodies to double-stranded DNA in the so-called SMEF antigen can be detected by more quantitative assays and are virtually diagnostic of systemic lupus erythematosus. Nevertheless, the staining pattern has diagnostic value and this test remains in use. In addition to anti-nuclear antibodies, lupus patients have a host of other autoantibodies. Some are directed against blood cells, such as red cells, platelets, and lymphocytes. Antiphospholipid antibodies are present in 30 to 40% of lupus patients. They are actually directed against epitopes of various plasma proteins that are revealed when the proteins are in complex with phospholipids. Antibodies against the phospholipid beta-2 glycoprotein complex also bind to cardiolipin antigen, used in syphilis serology, and therefore lupus patients may have a false positive test result to syphilis. Because these antibodies bind to phospholipids, they may prolong the partial thromboplastin time and in vitro clotting test that requires phospholipids. Therefore, these antibodies are sometimes referred to as lupus anticoagulant. Despite the observed clotting delays in vitro, patients with antiphospholipid antibodies have complications related to excessive clotting, such as thrombosis. The fundamental defect in systemic lupus erythematosus is a failure of the mechanism that maintains self-tolerance. Although what causes this failure of self-tolerance remains unknown, as is true of most autoimmune diseases, both genetic and environmental factors play a role. Many lines of evidence supported genetic predisposition to systemic lupus erythematosus. Family members have an increased risk for the development of systemic lupus erythematosus, and up to 20% of unaffected first-degree relatives have autoantibodies. There is a higher rate of concordance in monozygotic twins than in dizygotic twins. The odds ratio relative risk for patients with HLA DR2 or HLA DR3 is 2 to 3, and if both haplotypes are present, the risk is about 5. Other genes also play a role. Genetic deficiencies of classical pathways complement proteins, especially C1q, C2, or C4, are seen in about 10% of patients with systemic lupus erythematosus. The complement deficiencies may result in defective clearance of immune complexes and apoptotic cells and failure of B cell tolerance. A polymorphism in the inhibitory Fc receptor, Fc gamma RIIB, has been described in some patients. This may contribute to inadequate control of B cell activation. Additional genes have been implicated by genome-wide association studies, but their contribution to the development of the disease remains unclear. There are many indications that environmental factors are also involved in the pathogenesis of systemic lupus erythematosus. Exposure to UV light exacerbates the disease in many individuals. Ultraviolet irradiation may induce apoptosis and also may alter DNA and make it immunogenic, perhaps by enhancing its recognition by TLRs. In addition, ultraviolet light may modulate the immune response, for example, by stimulating keratinocytes to produce interleukin-1, a cytokine that promotes inflammation. The gender bias of systemic lupus erythematosus is partly attributable to actions of sex hormones and partly related to genes on the X chromosome independent of hormone effects. Drugs such as hydralazine, procainamide, and D-penicillamine can induce an systemic lupus erythematosus-like disorder. Recent studies in animal models and patients have revealed several immunologic aberrations that collectively may result in the persistent and uncontrolled activation of self-reactive lymphocytes. Failure of self-tolerance in B cells results from defective elimination of self-reactive B cells in the bone marrow or defects in peripheral tolerance mechanisms. CD4 plus helper T cells specific for nucleosomal antigens also escape tolerance and contribute to the production of high-affinity pathogenic autoantibodies. The autoantibodies in systemic lupus erythematosus show characteristic of T-cell-dependent antibodies produced in germinal centers, and increased numbers of follicular helper T cells have been detected in the blood of systemic lupus erythematosus patients. Type 1 interferons is also one of immunologic factors. Blood cells show a striking molecular signature that indicates exposure to interferon alpha, a type of interferon that is produced mainly by plasmacytoid dendritic cells. Some studies have shown that such cells from systemic lupus erythematosus patients produce abnormally large amounts of interferon alpha. TLR signal studies in animal models have shown that TLRs that recognize DNA and RNA, notably the DNA recognizing TLR9 and the RNA recognizing toll-like receptor 7, produce signals that activate B cells specific for self-nucleantigens. Other cytokines that may play a role in unregulated B cell activation include the tumor necrosis factor family member BAF, which promotes survival of B cells. In some patients and animal models, increased production of BAF has been reported, and this has led to modest success of an antibody that blocks BAF as a therapy for systemic lupus erythematosus. It is clear from the discussion earlier that the immunologic abnormalities in systemic lupus erythematosus are varied and complex. Nevertheless, an attempt can be made to synthesize results from human studies and animal models into a hypothetical model of the pathogenesis of systemic lupus erythematosus, as shown on the picture. Ultraviolet radiation and other environmental insults lead to apoptosis of cells. Inadequate clearance of the nuclei of the cells results in a large burden of nuclear antigens. Underlying abnormalities in B lymphocytes and T lymphocytes are responsible for defective tolerance, because of which self-reactive lymphocytes survive and remain functional. These lymphocytes are stimulated by nuclear self-antigens, and antibodies are produced against the antigens. Complexes of the antigens and antibodies bind to Fc receptors on B cells and dendritic cells and may be internalized. The nucleic acid components engage toll-like receptors and stimulate B cells to produce more autoantibodies. Toll-like receptors stimuli also activate dendritic cells to produce interferons and other cytokines, which further enhance the immune response and cause more apoptosis. The net result is a cycle of antigen release and immune activation, resulting in the production of high-affinity autoantibodies. Different autoantibodies are the cause of most of the lesions of systemic lupus erythematosus. Most of the systemic lesions are caused by immune complexes. DNA anti-DNA complexes can be detected in the glomeruli and small blood vessels. Low levels of serum complement and granular deposits of complement and immunoglobulins in the glomeruli further support the immune complex nature of the disease. T-cell infiltrates are often frequently seen in the kidneys, but the role of these cells in tissue damage is not established. Autoantibodies of different specificities contribute to the pathology and clinical manifestation of systemic lupus erythematosus. Autoantibodies specific for red blood cells, white blood cells, and platelets opsonize these cells and promote their phagocytosis, resulting in cytopenias. There is no evidence that anti-nuclear antibodies, which are involved in immune complex formation, can penetrate intact cells. If cell nuclei are exposed, however, the anti-nuclear antibodies can bind to them. In tissues, nuclei of damaged cell react with anti-nuclear antibodies, lose their chromatin pattern, and become homogeneous, producing so-called LE bodies or hematoxylin bodies. Related to this phenomenon are LE cells on the picture, which are rarely seen when blood is agitated in vitro. An LE cell is a phagocyte that has engulfed the denaturated nucleus of an injured cell. The demonstration of LE cell in vitro was used in the past as a test for systemic lupus erythematosus. With new techniques for detection of anti-nuclear antibodies, however, this test is now only of historic interest. Sometimes LE cells are found in pericardial or pleural effusions in patients. Patients with anti-phospholipid antibodies may develop venous and arterial thrombosis, which may be associated with recurrent spontaneous miscarriages and focal cerebral or ocular ischemia. This constellation of clinical features in association with lupus is referred to as the secondary anti-phospholipid antibody syndrome. The mechanism of thrombosis are not defined, and antibodies against clotting factors, platelets, and endothelial cells have all been proposed as being responsible for thrombosis. Some patients develop these autoantibodies and the clinical syndrome without associated systemic lupus erythematosus. They are said to have the primary antiphospholipid antibody syndrome. The neuropsychiatric manifestations of systemic lupus erythematosus have been attributed to antibodies that cross the blood-brain barrier and react with neurons or receptors for various neurotransmitters. However, this is not established in all cases, and mechanisms involving other immune factors such as cytokines also may underlie the cognitive dysfunction and other central nervous system abnormalities that are associated with systemic lupus erythematosus. The morphologic changes in systemic lupus erythematosus are extremely variable. The frequency of individual organ involvement is shown in the table on the slide. The most characteristic lesions result from immune complex deposition in blood vessels, kidney, connective tissue, and skin. An acute necrotizing vasculitis involving capillary small arteries shown on the picture by the star and arterioles may be present in any tissue. The arthritis leads to fibrinoid necrosis of the vessel walls. In chronic stages, vessels undergo fibrothickening as shown on the picture with luminal narrowing. Up to 50% of systemic lupus erythematosus patients have clinically significant renal involvement, and the kidney virtually always shows evidence of abnormality if examined by electron microscopy or immunofluorescence. Renal involvement takes a number of forms, all of which are associated with the deposition of immune complexes within the glomeruli. According to the currently accepted classification, 6 patterns of glomerular disease are recognized. It should be noted that there is overlap within these classes and that lesions may evolve from one class to another over time. Therefore, the exact percentage of patients with each of the 6 classes of lesions is difficult to determine. Minimal mesangial lupus nephritis class 1, mesangial proliferative lupus nephritis is a class 2, focal lupus nephritis is a class 3, diffuse lupus nephritis is a class 4, membranous lupus nephritis is a class 5, and advanced sclerosing lupus nephritis is a class 6. Suffice it to say that class 1 is the least common and class 4 is the most common pattern. Minimal mesangial lupus nephritis is very common and is characterized by immune complex deposition in the mesangium identified by immunofluorescence and by electron microscopy. You see immunofluorescence on the left picture, electron microscopy on the right, but without structural changes, this condition could be identified with the help of the light microscopy. Mesangial proliferative lupus nephritis is characterized by mesangial cell proliferation, often accompanied by accumulation of mesangial matrix. On the picture, you see glomerulus with a mild mesangial hypercellularity. The other characteristic are granular mesangial deposits of immunoglobulin and complement without involvement of glomerular capillaries. Focal lupus nephritis is defined by involvement of fewer than 50% of all glomeruli. The lesions may be segmental, affecting only a portion of glomerulus, or global, involving the entire glomerulus. Affected glomeruli may exhibit swelling and proliferation of endothelial and mesangial cells associated with leukocyte accumulation, capillary necrosis, and hyaline thrombi. Often, there also is extracapillary proliferation associated with focal necrosis and crescent formation. On the picture, you see a glomerulus with a segmental endocapillary hypercellularity, mesangial hypercellularity, and capillary wall thickening. The clinical presentation ranges from mild hematuria and proteinuria to acute renal insufficiency. Red blood cell casts in the urine are common when the disease is active. Some patients progress to diffuse glomerulonephritis. The active or proliferative or inflammatory lesions can heal completely or lead to chronic global or segmental glomerular scarring. Diffuse lupus nephritis is the most common and severe form of lupus nephritis. The lesions are identical to those in class 3 but differ in extent. In diffuse lupus nephritis, half or more of the glomeruli are affected. Involved glomeruli show proliferation of endothelial, mesangial, and epithelial cells, shown on the picture, with the latter producing cellular crescents that fill Bowman's space. Subendothelial immune complex deposits may create a circumferential thickening of the capillary wall, forming wire loop structures on light microscopy. Immune complexes can be readily detected by electron microscopy. On the picture on the left, you see an endothelial dense deposits on basement membrane that correspond to wire loops, both shown in light microscopy and with the help of immunofluorescence. Lesions may progress to scarring of glomeruli. Patients with diffuse glomerulonephritis are usually symptomatic, showing hematuria as well as proteinuria, hypertension, and mild to severe renal insufficiency are also common. Excuse me. Membranous lupus nephritis is characterized by diffuse thickening of the capillary walls due to deposition of subepithelial immune complexes similar to idiopathic membranous nephropathy. The immune complexes are usually accompanied by increased production of basement membrane-like material, resulting in holes and spikes on silverstrain. These lesions are usually accompanied by severe proteinuria or nephrotic syndrome and may occur concurrently with focal or diffuse lupus nephritis. Advanced sclerosing lupus nephritis is characterized by sclerosis, shown on the picture, and the sclerosis involves more than 90% of the glomeruli and represent end-stage renal disease. Changes in the interstitium and tubules are frequently present. Rarely, tubular interstitial lesions may be the dominant abnormality. Discrete immune complexes similar to those in glomeruli are present in the tubular or peritubular capillary basement membranes in many lupus nephritis patients. Sometimes there are well-organized B-cell follicles in the interstitium associated with plasma cells that may be sources of outer antibodies. Characteristic erythema affects the face along the bridge of the nose and cheeks. The butterfly rash in approximately 50% of patients, but a similar rash also may be seen on the extremities and trunk. Urticaria, bullae, maculopapular lesions, and ulcerations also occur. Exposure to sunlight incites or accentuates the erythema. Histologically, the involved areas show vacuolar degeneration of the basal layer of the epidermis. On the left picture, the liquefactive degeneration of the basal layer of the epidermis is shown by the red arrow. The histology also demonstrates edema at the demoepidermal junction, shown by the black arrow. In the dermis, there is variable edema and perivascular inflammation. Vasculitis with fibrinoid necrosis may be prominent. Immunofluorescence microscopy shows deposits of immunoglobulin and complement along the dermoepidermal junction. On the right picture, you see deposits of immunoglobulin along the dermoepidermal junction, shown by the yellow arrow. This also may be present in uninvolved skin. This finding is no diagnostic of systemic lupus erythematosus and is sometimes seen in scleroderma and dermatomyositis. Joints involvement is typically a non-erosive synovitis with little deformity, which contrasts with rheumatoid arthritis. Although it was suggested in the past that the neuropsychiatric manifestations of systemic lupus erythematosus may be due to acute vasculitis, in histologic studies of the nervous system in such patients, vasculitis is rarely present. Instead, non-inflammatory occlusion of small vessels by thrombi, shown on the right picture, or interval proliferation is sometimes noted, which may be due to endothelial damage caused by autoantibodies or immune complexes. Inflammation of the serosal lining membranes may be acute, subacute, or chronic. During the acute phase, the mesothelial surfaces are sometimes covered with fibrinous exudate. Later, they become thickened, opaque, and coated with shaggy fibrous tissue that may lead to partial or total obliteration of the serosal cavity. Pleural and pericardial effusions may be present. Cardiovascular system involvement may manifest as damage to any layer of the heart. Symptomatic or asymptomatic pericardial involvement is present in up to 50% of patients. Myocarditis is less common and may cause resting tachycardia and electrocardiographic abnormalities. Valvular endocarditis was more common prior to the widespread use of steroids. The sterile endocarditis takes the form of single or multiple 1 to 3 mm varicose deposits which may form on either surface of any heart valve, distinctively on either surface of the leaflets. The picture shows the vegetations attached to the margin of the thickened valve leaflet that is indicated by the arrow. By comparison, the vegetations in infective endocarditis are larger, while those in rheumatic heart disease are smaller and confined to the lines of closure of the valve leaflets. An increasing number of patients are affected by coronary artery disease manifesting as angina or myocardial infarction. This complication may be seen in young patients with long-standing disease and is especially prevalent in those who have been treated with corticosteroids. The pathogenesis of accelerated coronary atherosclerosis is unclear but is probably multifactorial. Risk factors for atherosclerosis, including hypertension, obesity, and hyperlipidemia, are more commonly present in systemic lupus erythematosus patients than in the population at large. In addition, immune complexes and anti-phospholipid antibodies may cause endothelial damage and promote atherosclerosis. Splenomegaly, capsular thickening, and follicular hyperplasia are common features. Central penicillary arteries may show concentric intimal and smooth muscle cell hyperplasia producing so-called onion skin lesions, as could be seen on the picture. In addition to pleuritis and accompanying pleural effusions, some cases are complicated by chronic interstitial fibrosis and secondary pulmonary hypertension. Hematoxylin bodies in the bone marrow or other organs are strongly indicative of systemic lupus erythematosus. Lymph nodes shown on the picture may be enlarged due to hyperplasia of B cell follicles, or even demonstrate necrotizing lymphadenitis due to vasculitis. Systemic lupus erythematosus is a highly variable multi-system disease, and its diagnosis relies on constellation of clinical, serologic, and morphological findings. It may be acute or insidious in its onset. Often the patient is a young woman with some or all of the following features: a butterfly rash on the face, fever, pain without deformity in one or more joints, pleurotic chest pain, and photosensitivity. In many patients, however, the presentation is subtle and puzzling, taking forms such as fever of unknown origin, abnormal urinary findings, or joint disease masquerading as rheumatoid arthritis or rheumatic fever. Generic anti-nuclear antibodies detected by immunofluorescence assays are found in virtually 100% of patients, but these are not specific for the systemic lupus erythematosus. Renal involvement may produce a variety of findings, including hematuria, red blood cell counts, proteinuria, and nephrotic syndrome. Anemia or thrombocytopenia are presenting manifestations in some patients and may be dominant clinical problems. In others, neuropsychiatric manifestations, including psychosis or convulsions, or coronary artery disease, may be prominent. Infections are also common, presumably because of the immune dysfunction that underlies systemic lupus erythematosus, as well as treatment with immunosuppressive drugs. The cause of systemic lupus erythematosus is variable and unpredictable. Rare acute cases result in death within weeks to months. More often, with appropriate therapy, systemic lupus erythematosus follows a relapsing and remitting course over a period of years or decades. During acute flares, increased formation of immune complexes results in complement activation, often leading to hypocomplementemia. Disease flares are usually treated with corticosteroids or other immunosuppressive drugs. Even without therapy, in some patients, the disease runs an indolent course for years with relatively mild manifestations such as skin changes and mild hematuria. The overall 5-year and 10-year survivals are approximately 90 and 80% respectively. The most common causes of death are renal failure and intercurrent infections. Coronary artery disease also is becoming an important cause of death. Patients treated with steroids and immunosuppressive drugs incur the usual risks associated with such therapy. As mentioned earlier, involvement of skin along with multi-system disease is fairly common in systemic lupus erythematosus. Next, we will look into two syndromes in which the cutaneous involvement is the exclusive or most prominent feature. Chronic discoid lupus erythematosus is a disease in which the skin manifestations may mimic systemic lupus erythematosus, but systemic manifestations are rare. It is characterized by the presence of skin plaques, most often on the face and scalp, showing varying degrees of edema, erythema, scaliness, follicular plugging, and skin atrophy surrounded by an elevated erythematous border. It progresses to systemic lupus erythematosus in 5 to 10% of patients, usually after many years. Conversely, some patients with systemic lupus erythematosus may have prominent discoid lesions in the skin. Approximately 35% of patients have a positive test for generic ANAs, but antibodies to double-stranded DNA are rarely present. Immunofluorescence studies of skin biopsy specimens showed deposition of immunoglobulin and C3 at the dermoepidermal junction, similar to the systemic lupus erythematosus. The term subacute cutaneous lupus erythematosus refers to a group intermediate between systemic lupus erythematosus and lupus erythematosus localized only to skin. The skin rash in this disease tends to be widespread and superficial. Most patients have mild systemic symptoms similar to those in systemic lupus erythematosus. There is a strong association with antibodies to the SSA antigen and with the HLA and DR3 genotype. Drug-induced lupus erythematosus, shown on the left picture with arterial vasculitis and on the right picture with hypersensitivity vasculitis. And systemic lupus erythematosus-like syndrome may develop in patients receiving a variety of drugs, including hydralazine, procainamide, isoniazid, and D-penicillamine. Surprisingly, anti-tumor necrosis factor therapy, which is effective in rheumatoid arthritis and other autoimmune diseases, also can cause drug-induced lupus. Many of these drugs are associated with the development of anti-nuclear antibodies, especially antibodies specific for histones. The disease remits after withdrawal of the offending drug. In a summary, it could be said that systemic lupus erythematosus is a systemic autoimmune disease caused by autoantibodies produced against numerous self-antigens and the formation of immune complexes. The major autoantibodies and the ones responsible for the formation of circulating immune complexes are directed against nuclear antigens. Other autoantibodies react with red blood cells, platelets, and various phospholipid proteins complexes. Disease manifestations include nephritis, skin lesions, and arthritis that is caused by deposition of immune complexes, as well as hematologic abnormalities caused by antibodies against red cells, white cells, and platelets, and neurologic abnormalities caused by obscure mechanisms. The underlying cause of the breakdown in self-tolerance in systemic lupus erythematosus is unknown. Non-exclusive possibilities include excessive generation or persistence of nuclear antigens in individuals with inherited susceptibility genes and environmental triggers, including ultraviolet irradiation, which results in cellular apoptosis and release of nuclear antigens. Thank you for your attention.